people who can't be there right now be able to have a recording of what we learned from Dr. Raskin. And I must say, I am thrilled to welcome back to Mended Hearts number 188, one of our favorite speakers, Dr. Stephen Raskin. Dr. Raskin is an interventional cardiologist, someone who works upstream to prevent myocardial infractions, MIs, with medications. Dr. Raskin has practiced clinical cardiology for over 38 years and is a clinical professor of medicine at UCSF and a mentor at the UC Berkeley UCSF Combined Medical School program. In addition, he's the director of the East Bay Sutter Lipid Clinic. Dr. Raskin wowed our June 2018 meeting with his engaging evidence-based talk explaining new discoveries in LDL cholesterol particles. Dr. Raskin's message then was, just when we thought if our LDL cholesterol numbers were lower than 100, we were safe from a heart attack or a stroke. Now, evidence shows we may not be safe. In fact, he told us then that most people with MI do not have high cholesterol. 75% of heart patients have LDL-C considered normal or low. So there must be some other factor at work that we're missing, and our LDL test needs an upgrade. He's back today with an update on all those smaller LDL particles that are the real culprits, as well as new information on triglycerides, with a talk on lipids and cardio risks, what the traditional panels miss. Dr. Raskin.
Thank you so much. I appreciate that, Laura. Let's see, I think we're turning the screen over to me, and I will like to show you, let's see, share screen. I'm on share screen, and okay, here we go. So, I think, Laura, you basically gave a summary of what I'm talking about, and thank you. So, we're going to focus this morning a bit on cholesterol and the nuances behind it. As everyone here is aware, there are the facts, and then there's much more to it. There's nuance to just about everything. So we're going to talk about the underlying process, the disease process that really underlies most of the cardiovascular disease we care about. And it mended hearts ever since Dwight Harkin did the first surgery. He was very much, I understand, one of your founders. And the concept now, of course, is to try to move the bar earlier to prevent us from becoming patients. And since the #1 killer on the planet now, which is pretty amazing when I just say that, not only for men, but for women in the US and the world, even in the COVID era, more than 800,000 people die of atherosclerotic vascular disease, which underlies most of the heart disease that we hear about. When we talk about cardiovascular, there are many aspects to that. The single biggest has to do with atherosclerosis. So we got to talk about why, something about particles, targets, goals for therapy, the emerging importance of inflammation, and how this new data affects what we call residual risk. You commented in the introduction that there's more to the LDL-C. So I'm going to try to give you a little bit of a feel for that. So atherosclerosis actually comes from a Greek word, athero and sclerosis. Athero is the gruel, the soft part of the hardening of the arteries. The term hardening of the arteries comes from the sclerosis part of the word, meaning hard, the calcium, the hard part. So the calcium, in fact, is the tip of the iceberg. When we visualize calcium on an X-ray or a so-called coronary artery calcium scan, we are seeing a marker, not the whole thing, a marker of atherosclerosis. Shows up very nicely, calcium. Women know that. You want strong bones. X-rays are great for looking at bone. And indeed, X-ray technology now is an early warning type of study to see is hardening arteries there because of the telltale calcium. Calcium makes up about 20% of the atherosclerotic plaque. What I'm going to be introducing here are some cartoons. Many of you may not know, but at one point I wanted to be a cartoonist. When I was in college during the first televised war, you know, Vietnam, I was a political cartoonist at City College in New York. And after a total knee operation about a year ago, I had a lot of time on my hands to start doodling and putting together concepts that I talk about to my patients visually. So I'm putting these together into a book, as a matter of fact. So you're going to see a little bit of my cartooning. So here's the atherosclerosis, literally a single very important thing for all of us to be thinking about. And the reason we think about it, here is a CT angiogram, a novel way without putting the tube in the heart to see this picture of an incredible picture of the two main coronary arteries, the left on the right side of the screen and the right coronary. And as you can see, the left has two big branches, the left anterior descending and the left circumflex, and off on the right is a picture of an angiogram. Now, for decades, we have looked at the angiogram and considered hardening of the arteries a disease. You have it or you don't based on blockage. Well, if you wait for the blockage to cause angina, if you wait for the blockage to narrow those tubes, those lifelines, you missed 20 years, 30 years of preventive therapy that could have stopped those tubes from getting plugged. And that's the essence of why the classic definition of an interventional cardiologist is someone who opens arteries. I would contend that a real interventionalist is preventing the arteries from getting blocked and keeping them pristine, like in this example. So, big problem. Cardiovascular disease, major issue. The single biggest part of cardiovascular is related to atherosclerosis. What causes it? It starts off, I was lucky enough when I was in my training in Boston, at Boston City, to spend, I think we spent about 4 to 6 months in the town of Framingham at the hospital there, right next door, literally, to where the whole concept of risk factors evolved from the famous Framingham heart study. Began really in 1948. The data was first published in 59, and we had a scoring system. If you had more of the scores, like blood pressure, smoking, high cholesterol, sedentary behavior, low HDL, you had a greater likelihood of getting this. So this is where the concept of factors of risk, and you've all heard this, risk factors, very important. With primordial prevention, with prevention, we're trying to prevent the risk factors from even showing up. So this is from the original paper. First follow-up. This was a seminal change from moving from treating patients to preventing disease. And of course, we rediscovered the concept that wouldn't it be nice for wellness and a holistic approach? So there's a great expression, the new is the old relearned. So I like to bring in a little bit of the history. But needless to say, we're going to focus on cholesterol. It's commonly looked at, and for 50 years, we've been estimating the bad cholesterol called LDL cholesterol. That's a target. That's an important. And we do a standard lipid test that's been in operation for 50 years. But I know everyone here in this discussion, when you see your doctor, you would like, what's the up-to-date recommendation? You don't want the best medicine from 1971. Well, in 1971, Friedwald devised an equation to estimate the LDL-C. What really is important is the content of cholesterol in lipoproteins. A little different than the LDL-C, but the LDL-C is a 35,000-foot view. It works. It's a starting point. But the essence of hardening of the arteries is due to these little particles, LDL, intermediate density lipoprotein, types of very low density lipoprotein. These are particles. These are particles the size of a rhinovirus, 30 nanometers. This is small. And within these particles is the culprit cholesterol, which gets into the wall of the artery, gets beyond the lining, our Teflon coating of all our blood vessels is called the endothelium. And if these particles penetrate that lining in all of our blood vessels and stay there, it sets up a maladaptive, inflammatory, immune-mediated process that we call atherosclerosis. And this process starts in our 20s. Someone who had a heart attack at 65, the disease started decades earlier. And the whole process is the retention or the subendothelial, meaning beyond the lining of our blood vessels, beyond the endothelium. These little critters set up housekeeping and set the process. Now, for more than 50 years, we've been looking at LDL-C, which is a reasonable surrogate for these particles. And what's unique about these little particles is they carry a protein. The protein is called the B protein. And we give it a fancy name when these additional proteins live on the lipoprotein particles, and it's called apolipoprotein B. So the B protein on these little critters identifies which of these little submicroscopic particles are really the dangerous ones. So there's just the first point, there's a subtle but very important difference between the common test measuring or estimating, I should say, the LDL cholesterol from particles. So the target of therapy has been LDL cholesterol or LDL because it's easy to do. It gives you a starting point, and we do have data about the target and the goal. The goals are important. You know, you take blood pressure pills, some people think I'm good to go. No, you got to look at the response. Are you at the target? Are you at the goal, I should say? And many of you know the LDL cholesterol goals have been getting lower and lower as more evidence is accruing that lower seems to be better. So we're going to just walk through a little bit of this, and part of the data on LDL cholesterol and the benefit of lowering it has to do with the most common drug prescribed in America are statins. And they block some of the critical chemistry of what makes cholesterol. And there's an enzyme called HM coreductase, which is blocked. It lowers the cholesterol in the liver, And the liver responds to that by saying, where's my cholesterol? You're blocking it. So the liver is very, very smart. And what the liver then does is make more LDL receptors. These receptors grab the particles that have a B protein, the ApoB. So they basically, like baseball gloves, catch the LDL lipoprotein that has the B protein and drops the LDL. We have to credit Brown and Goldstein, who discovered the LDL receptor. This is metaphorically. And it turns out that the LDL receptor is the critical piece of the whole concept of cholesterol metabolism. And we do a lot of things to try to increase the LDL receptors to lower the LDL cholesterol. And here's an example of an LDL receptor on the surface of the liver, the ApoB component being attracted to the LDL receptor, drops down your cholesterol. Very, very important concept. Nobel Prize in Medicine and Physiology was awarded to these people, and Brown and Goldstein, and it was a set the whole process moving with statins. And many of you know there are a lot of other drugs we're now using, and much of the commonality is you got to increase the LDL receptor. And what we also know is that lowering cholesterol does indeed work. The statins do work. In over 90,000 people in a pivotal meta-analysis, which means a collection of randomized controlled trials over a number of years, found that about a 40 milligram per deciliter drop, you get almost a 25% lowered reduction of heart attack or cardiovascular death. When you look at this type of data, the chances of getting hit by a bus drop. That's what we call all-cause mortality, meaning you don't want to have less heart attacks but have more cancer. All-cause mortality is what is the holy grail of randomized trials. You don't want to substitute a good outcome with more bad outcomes. So the totality of data says this indeed works. And this is kind of the pivotal backbone to therapy. We've had hundreds of subsequent trials. Let me just show you a little bit of the cycle. There's the LDL particle being attracted to the receptor. It gets into the liver, and basically the cholesterol content is then dissolved in this, what we call a lysosome. But what I want you to see is the LDL receptor goes back up and cycles right back to the surface of the cell here. And this cycle goes on for days, and anything that might increase the number of LDL receptors, the better. A new class of drugs, some of you are aware of, from two big companies. You may have heard this morning, the president apparently got a monoclonal antibody. These are space-age kind of therapies, a monoclonal antibody against the coronavirus to try to grab the coronavirus and neutralize it. Well, in fact, one of the monoclonal antibody successes has been in this concept of cholesterol metabolism called PCSK9 inhibitors. These are the injectable, they're antibodies that are attacking, in this case, the PCSK9 protein. Off on the left of your screen, you see this little guy. PCSK9 is being made in the nucleus of the cell. The LDL receptors are also being made at the nucleus. And you know about the LDL receptor now. This monoclonal antibody, the Y, is blocking a protein that if you have a lot of that PCSK9 around, you're going to destroy your LDL receptors. You're going to prevent the recycling or the repackaging of the LDL receptor to go back up to the surface. Hence, the lifespan of the LDL receptors is greatly increased. You can lower LDL another 70%. And a question that often comes up, well, isn't it dangerous to have LDL real low? Well, you see that in one of the pivotal trials with the PCSK9 inhibitor drug called Repatha, in the Fourier trial, thousands of people were studied, and the lower your LDL, even down to 20, there was dramatic lowering of risk. What about side effects? Turns out that even they had even 500 patients or so below 10 equivalent cholesterol of a New Zealand white rabbit. Additional lowering of risk, whether your LDL was greater than 100 or less than 10. So it seems, based on randomized evidence, that lower seems to be better. And this was a pivotal trial. In terms of safety, liver, muscles, hemorrhagic stroke, new diabetes. When you look at these bars between LDLs less than 20 or over 100, there was no added risk. Neurocognitive brain fog often shows up in social media as a concern. It appeared that lower did not increase any of these important potential risks, from diabetes, cancer, neurocognitive. So it's a good safety signal for us. There's a subhuman primate, a newborn. What do they have in common? So newborns, when they're growing, in fact, cord blood, average LDLs are in the 50s. Hunter-gatherer populations who do not get atherosclerosis are walking around with cholesterol levels. This isn't the LDL, this is the cholesterol, very low. If you were lucky enough to have a genetic mutation, think about this. If you have a mutation in your body where you do not make that protein called PCSK9, you're going to have more LDL receptors from the moment you're born. And compared to the top bar graph and the lower is the distribution of cholesterol in about 2% of African Americans in the United States. They carry this mutation, which means they're always going to have lower LDL compared to the rest of us. So if you have a mutation that'll lower your LDL for your whole life, not starting a statin when you're 40 or 50 or 60, or unfortunately for too many people after the heart attack, you have nearly a 90% lowered risk of heart attacks at 15 years. So not only is lower better, starting earlier is better. So that's a conceptual idea. And how does this work? What literally happens, and this is a photomicrograph of someone who had passed of a coronary artery. And that asterisk is in the middle of the soft gruel, the lipid, the cholesterol in a plaque, in an atherosclerotic plaque. All around it is fibrous tissue and calcium. And that between the arrows are white blood cells or inflammation. What we want to do is cut the inflammation. We want to shrink that yellow material. And that indeed can occur when we lower cholesterol. And one of the early studies, now over 30 years ago, by Greg Brown up in Seattle, looked at can we really get plaque to regress, to shrink? And back in those days, the imaging we had were called angiograms, and many of you know that. And at the top panel are blockages, and below it, or after aggressive therapy with aggressive lowering of LDL, you literally see plaque regress. And that we now have more contemporary studies, for instance, with the Repatha, the PCSK9 monoclonal antibody that lowers PCSK9 protein. The greater the LDL treatment, the greater the lowering of the LDL, the more regression of volume of plaque. So there is a potential vulnerable plaque. This is somebody who had the disaster of the plaque breaking. So take a look at this. The cap between the arrows, if that gets inflamed and breaks, or fissures or ruptures, it sets a process and very quickly can clot the blood. You see the break off on the left. If we had the opportunity to shrink the plaque, that helps prevent this process of what's called plaque rupture. And this is just other studies just to remind me to tell you that there are other ways of looking at this, and the lower your LDL over time seems to have a much more powerful lowering of risk. Remember, the studies that powered up the concept of statin use, PCSK9 use, are short-term studies from 3 years to 5 years. We want something with we want to look at it with a lens that tells us about a longer period of time with greater outcomes. And these kind of genetic analyses inform us that we probably should be looking earlier. And the concept, these are abbreviations for a number of the pivotal statin trials, the West of Scotland trial, the Air Force trial, and the Anglo-Scottish trial. These trials are basically showing as you lower the LDL cholesterol, you indeed lower risk. And the question is, can we really prevent the disease from showing up? It started off with the statin trials as a statin hypothesis. Now that we have other drugs and we have genetic studies now, these genetic studies and others now tell us it's the LDL hypothesis, the low density lipoproteins, again, estimated from the LDL cholesterol, the lower the better. But there's more to it. Heart attacks, strokes may be genetic. And we're going to talk a little bit about that. Anybody see anything here? Well, there's a curious an arc at the lower pole of the eye. See, the cornea is right here. There's the pupil. There's the white of the eye. And around the circumference of the eye, and I'm sure you look at people, you may look at people a little differently after this, that's a sign of high cholesterol, particularly if it occurs in a young person in their 30s or 20s. Other manifestations of high cholesterol are these little yellowish spots on the eyelid. They're called xanthelasma. I recently saw a 40-year-old who thought everything was great. Whoops, sorry about that. Thought everything was great. Her doc thought everything was great. The HDL was 110. And remember, we used to talk about cholesterol to HDL ratio. So her cholesterol was 350, her HDL was 110, her ratio was well below 3.5. But curiously, when I looked at her tendons here, these are the Achilles tendons, it was thickened and nodular. And she had what we call tendon xanthomas, and had tendon xanthomas on the extensor tendons of the hand. This is a condition that's called familial hypercholesterolemia, abbreviated FH. If you go back hundreds and hundreds and hundreds of years ago, I think into the early 16th century, you see xanthelasma in this painting on the right. You see tendon xanthoma on the extensor surface. It's the Mona Lisa. The Mona Lisa is one of the earliest representations of FH. FH is a severe problem with very high cholesterol. Typically, the LDL is over 190. If you're a woman, like the patient I saw with FH, there's literally a approximate 30% increased risk of fatal and non-fatal cardiovascular events before 60. If you're a man with this condition, half of the men by 50 have problems that are big problems. This is FH, and in the United States, strikingly, sadly, less than 10% of Americans are even diagnosed and treated. My patient had FH, wasn't being treated. The presumption had been the HDL is protective, but there's more to say about HDL. It may not be protective. In my patient's case, it wasn't protected. She had FH, and for decades, her LDLs were 190, 195, go on a diet. No, this is genetic. It's a genetic problem affecting the LDL receptors. That's the most common problem. This is just what we call a Manhattan plot, looking at mutations of the LDL receptor gene. One of the main causes of this. HDL, we thought, was the good stuff. What's going on? Well, it turns out it's very Janus-like. It could turn from good to dysfunctional. There are more and more studies showing very high HDL may in fact be dysfunctional and not protective. Many of these studies came from Copenhagen. Across the bay at UC San Francisco, my colleague, Dr. John Kane, is looking at a particle, again, we're back to particles, related to HDL, which it may tell us more about the function of HDL, because you could have a lot of cholesterol in your HDL. See, when we talk about HDL, it's the HDL cholesterol content, HDL-C. Is that the same as the HDL particles? No, they're related, but not the same. And so when you look deeper, you put the glasses on to look at particles, we're learning a lot more. The take home, you can't trust HDL-C. So how do we talk about who's vulnerable? What's going on? And this was already somebody remembered very well my last lecture, but this is a large data set from the American Heart Association program called Get With the Guidelines. They looked at over 230,000 hospitalizations across the country, and they asked this question: what are the lipid levels when you go in with your first heart problem, your first cardiovascular event? Turned out more than 75% of acute coronary syndrome, that's our term for a heart attack, presented with LDL below the mean or average of 130. About a quarter had LDLs less than 70. So again, this is more nuance. MI, heart attack with normal LDL or so-called normal LDL. So can you trust LDL-C? Is it a false idol? Now, don't get me wrong, the LDL-C is an everyday important look, but you've got to get to the root. You got to look beyond this. And in primary prevention, meaning you're a healthy 50-year-old with a perfect LDL, but you're questioning, I heard you could have a perfect LDL and have a problem. And in my cartoon here, you see this angel coming down, says, image, and ye shall find. Well, why do we image? Well, women know that. How many women in this meeting have had mammograms? Most of us have had colonoscopy. You want to catch it early. You want to catch it early. If you catch it early, you can do something about it. An LDL-C that's perfect, an HDL that looks perfect, and you have a family history, people have had heart, vascular, stroke, peripheral arterial disease, maybe you want to look deeper. Image. You know, if you add up all the cancers we're all subject to, about 1 in 5 of us do get cancer. If you add up all of the cancers, cardiovascular is still #1. And that's just a crying shame when you could image and find this disease decades before an event. We know risk factors are important, but critical analysis, particularly if you're under 65, finds that most people under age 65 don't have a lot of risk factors and may have a paucity of risk factors, may have an average LDL. So this is from a large data set of people actually showing up with heart attacks. When I was in Alameda, we were early participants of the National Registry of Heart Attacks, NRMI. Kind of stunning when you look at the hard evidence. That doesn't mean risk factors aren't important, but remember the first opening comments. This is a common problem. High-risk people are easy to find. It's us average folks, and many of us are average. There's question as to who may have risk. And on the other end of the coin, this is from the Repatha trial, the PCSK9. It showed lower event rates. The red is the effect of the drug, lowered risk, but there's what we call residual risk. Even with on the red line, you can see a 5% per year residual risk. People are still having events. And registry data shows us that 4 years out, of 20 to 30% of people are having events in spite of their LDL being down. So this is despite an LDL of 32, there's a significant risk, or we call it residual risk. And you look at all the statin trials, what? Long-term, after 5 years, 6 years, still having adverse events. Well, my colleague Ron Krause, who's had worked for years at the Children's Hospital and the Research Center, was one of the leaders of the concept that there's more to the LDL, and it may track with your triglycerides being high. And what he found is that LDL is not one thing. LDL-C of 130 in this cartoon is the same whether you're on the left or the right. Same amount of cholesterol in the LDL, but the LDL particles on the right are smaller. Interesting. What happens when they're smaller? Well, to carry the same weight of cholesterol, you'll need more of these little packets or particles filled with cholesterol, because each single lipoprotein smaller, it carries less cholesterol. The risk is related to the number of LDL particles. Tells us more than the LDL cholesterol. It's true, the higher the LDL cholesterol, the worse, the lower the better. But what about an average LDL-C of 130? There's question, who may be at risk? Here's Ron Krause, and he helped define a pattern that we call pattern B, a predominance of your LDL critters, your LDL particles, are B flavor. B offers a greater risk. And what happens is these particles, again, they're very, very small, but when you can shift the particles to smaller or back to larger, depending on the sugar in your diet, the amount of processed carbs, ice cream, various things. So it's more subtle than, oh yeah, I know what's bad for my cholesterol. It's much more subtle. And in fact, going on a low cholesterol diet and not informing someone that, you know, you might want to watch the potatoes, the pasta, the good sourdough bread, and the sugar and the hidden sugar in so many items. Because you can, if you're subject to this, you may not realize you're changing your particles and increasing your particles. This is all related to very basic physics. The volume of a small change in the radius of a particle changes the amount that particle can actually, the space within, or the volume within the particle, and how much cholesterol can be carried. So particles matter. You could have a low LDL cholesterol and have a high LDL particle number, as shown in the Framingham offspring study. If just people on the bottom of this curve in that pinkish reddish color, low LDL, but high LDL particle, had risk. If you had a high LDL, the lighter colors up above, but had a low LDL particle number, hence you had larger particles, your risk was lower. The risk is related to the number of the particles. Now, over the last 30 years, our triglycerides in the US have been increasing as the LDL in the bottom here has been dropping since 1976, but the triglycerides are going up with our waist circumference. We know that diabetes is now being seen in children in middle school. And in fact, about 30 to 40% of Americans have pre-diabetes, which often is associated with triglyceride disorders. And there's risk with triglycerides. We now know that even if your LDL is great, you hit your goal of LDL 70, not knowing that your triglycerides are 150 or greater, you're headed for trouble, particularly a high-risk person. There was a high-risk person would be a diabetic with risk factors, person who had a vascular event already, thinks everything's great. This has been informed by the Reduce It trial. A couple of years ago, there was a trial of a product that we call Vazipa. Vazipa, some of you know, is a omega-3 product. It's not your run-of-the-mill supplement, not intended to treat any disease, as you know. EPA is the name of one of the omega-3s. So this is a pure form, Vazipa is, of EPA, one of the omega-3s, or fish oil. So we have omega-6s, we have omega-3s. And on the right is an example of, from flaxseed oil, alpha-linolenic acid is a plant-derived omega-3. And below that are the, quote, fish oil constituents. The most well-studied is the eicosapentaenoic acid, that's EPA, that's what's in Vazipa, and DHA. So in this study, they looked at the effect of EPA in people who had triglycerides of 150, and what happens? These are high-risk people who either had an event or had diabetes, and they were older and had other risk factors. And this is just to show you the membranes in our body are actually very fluid. And this is the endothelium. And in between these phospholipids, they're called, as part of the membrane wall, there are these little yellow guys in there, which is cholesterol. That's where cholesterol can start to penetrate into the wall. And it turns out the EPA can get into the membrane and help block the process. The reason we know triglycerides are clearly a risk factor is that with this Vazipa medicine, the medical name is icosapent-ethyl, people who had triglycerides of actually 135 or greater up to 500 had a significant lowering of risk, even if their LDL was 50, 60, or 70. That means less cardiovascular death, heart attack, stroke, need for another procedure was dramatically lowered. So without that medicine, this is also telling us, this is a contemporary trial, it was published in last year. It's telling us there's a lot of residual risk. And the triglycerides dropped. This was a mean of 216, they dropped. But one of the significant changes that occurred is your EPA level in your blood rose dramatically. And it turns out a lot of this benefit has to do with this special omega-3. The marker of risk was the higher triglycerides. This is my attempt to tell you about another story. Celebrity trainer Bob Harper. This young man in his early 50s had a TV show called The Biggest Loser. And he was helping people in this reality TV optimize their weight and their vascular health. Unfortunately, he had a near fatal heart attack. This guy's risk was low, good shape, low LDL, normal blood pressure, non-smoker. The family history is the elephant in the room. And he turned out to have a particle called Lp(a). It was found after he was defibrillated, after he recovered from a near fatal heart attack where his heart had stopped. This little critter called Lp(a), we've known about for decades, and we measure it. It's inexpensive, it's measurable, and is a major additional risk factor for heart attacks, irrespective of your LDL. It's a ApoB particle, there's the ApoB, and it has this funny curly protein called a. So it's like LDL, but it's an LDL on steroids. It increases your risk, and it's not rare. It's seen in 20 to 30% of Americans. It should be looked at in everyone once. It's genetic. If we're on the fence on who needs cholesterol lowering and you have an average LDL, but your Lp(a) is very high, we get off the fence. The crime is it's not being looked at very often. And here's my representation of this crazy protein Lp(a) bridge to LDL. Very shortly, we will have a drug. It is hoped. It's in phase 3 trials. A researcher in San Diego area is working on what's called an antisense. It's a molecule to actually block the genes from making this. If you have it, 50% of your children have it. But it's more than just particles. There's inflammation. We think of atherosclerosis as a double-headed monster, as inflammation. We recently had a trial headed by Paul Ritker at Harvard that showed blocking one of the markers of inflammation could dramatically lower cardiovascular risk again, over and above perfect LDL cholesterol. As an example, we've known that rheumatoid arthritis, psoriasis are inflammatory diseases. What does that have to do with heart? On the left is an aorta filled with plaque. Just to bring, for example, that we now know that if you have an inflammatory disorder, and again, your LDL looks great, well, it turns out your risk for heart attacks is much, much higher. And again, that might be the reason I better be more aggressive. One of the simple tests is called CRP, high sensitivity CRP. This is just showing that as a predictor, when you add CRP to another marker that we call PLA2 or lipoprotein PLA2, another marker of inflammation, it's much, much stronger in predicting heart attacks and stroke. So we know lower is better. High is definitely bad. Average may not be so good. So our choices, this is a real problem in the US. Someone has a heart attack every 40 seconds. Much greater a concern for all of us than COVID. Terrible as COVID is, hopefully in the next 6 months, there'll be significant turnaround in COVID. We're doing great with procedures, advanced procedures, keeping people alive and better quality of life. But there's a way to help prevent first events. We think since so many events occur around mid-age, moving earlier on this curve, earlier when you first see evidence of plaque might make more sense. And just a last word about diet, because that's so connected to good lifestyle. Way back in the 60s, there were small studies suggesting benefit, and the trend had been, well, cholesterol's not good. Let's cut the cholesterol out in our diet. Well, it's more nuanced. I showed you that carbohydrates could be a culprit, or simple carbohydrates, and we have to think more holistically, because nutrition, when you look upstream, is really the #1 aspect that informs risk much greater than anything else we got on this planet. So good nutrition helps prevent the risk factors. Good nutrition helps prevent 80% of cardiovascular disease. Big deal. So thank you very much. And I'll leave you with this. Okay, and that's it. I'm sorry I ran a little late. And you can't hear me? Well,
Yes.
Let's see what happens.
Yes, they can all hear you and I can all hear you. And I'm now going to unmute everybody. If anybody has a question.
Hello, Dr. Raskin. My name is David Smith. And
can you hear me?
Yeah. Can you hear me?
You can unmute, I guess. And
can you hear me?
I can hear David Smith.
Answer questions.
Yes, sir.
I don't hear anyone.
Important is to say thank you. I was there when you made the presentation about
here you go. Now I had my computer muted for a while. So can you repeat your question?
Yeah, my first thing is to say thanks.
You're welcome.
I was in the meeting with you about a year or 2 years ago at Mended Hearts at Kaiser, and I found your presentation terrific.
Well, thank you.
So that's now taking what you've said. I have both LP(a) and I have an issue with small particle cholesterol. Yeah. What I find disturbing is that as a patient at Kaiser, they do not test for LP(a), nor do they test for small particle LDL. I am told by my cardiologist that they find there's no research that's definitive, and therefore they do not think it appropriate to do any testing. I just had my lipid test done yesterday at Kaiser, and again, they did not do LP(a) or so I am a patient of Dr. Kraus.
Oh, good, run, yeah.
And I get my lipids done by Quest. And
Yes.
he has special lipid tests designed to ascertain one's Lp(a) and also one's quantity of small particle LDL and large particle LDL. And so my treatment that I get from him is quite specific, looking at Lp(a) and small particle. So I caution those who are members of Kaiser that if indeed you find that this is an interesting topic, you won't get a result by talking to your Kaiser cardiologist, very sadly. So you need to go to a cardiologist who is looking at exactly what Dr. Raskin says one should look at. So that's it for me. Thank you.
Thank you. I appreciate what you said. And I look, the American College of Cardiology and the American Heart Association are that's where guidelines come from. They're respected societies. And even though they're relatively conservative, would say, if you're unsure of your risk, Lp(a) would make sense. It's true we don't have specific therapy to lower Lp(a), but that doesn't mean we don't look at this, because it informs about risk. So if your LDL is now 70, but you know you have high Lp(a), it tells us maybe you need it lower. If you're in primary prevention, meaning you never had a vascular event, and as you know, if you have high Lp(a), your family members have a 50% chance of having it. So some of your family members never heard the word heart attack or vascular, but they have this risk factor. It's something you cannot ignore. It's at your own peril, because if you knew you had very high Lp(a), multiple guideline organizations across Europe, the United States would say, you know, maybe it's time to take a statin, and yes, you might need an aspirin because Lp(a) can make the blood stickier. If you didn't know that missing piece and relied only on, well, my HDL's good, oh, my LDL's average, you're missing an opportunity. So, I mean, that's how we think about it, and many of the thought leaders would agree.
Dr. Raskin, we have Linda Vital has a couple questions. Linda, you want to?
Sure.
You should read it.
Okay. What she wrote in the chat room was, so what do we do if we have high Lp(a) and have already had a heart attack, and at the time I had been considered as having low risk factors? Is there a test for small particle LDL, and how do we get out our cardiologist to do it?
How do you get people the last part's the hardest one. But if you have high Lp(a), it sometimes tells us in secondary prevention, meaning you've already had an event, you've already had a vascular problem, you might be considered at higher risk, and we now know that there's a new category of higher risk to move LDL cholesterol below 50, below 55. So you might need more aggressive therapy. And if you have Lp(a), the important thing is to relate this to your relatives, because it's inherited. In terms of added risk like particle number, if your LDL cholesterol is now way down in the 40s and 50s, the relative likelihood that more particles exist in the LDL becomes much lower, a clinical issue. The issue is more often your LDL's around 70, your triglycerides intermittently are going up and down around 150. The process is evident from the triglycerides. That's more likely than not you have high particles even though the LDL looks good. And so specifically looking at an analysis that's available at Quest, it's available at LabCorp, it's all over, can tell you your particle number, can tell you if you're the pattern B person, the pattern A person, which really is the type of LDL. So there's more than the LDL-C. And if you have had, if you're diabetic, if you have prediabetes, or you have triglycerides that are in the 135, 150 range, it's very likely your particles are discordantly higher, meaning the LDL-C looks good and is low. If it's at 70, it's at the 20th percentile or lower in the population, but your particles may be really high. So it's more of an individual decision. It's not something we do for everybody. And sometimes we have other markers that tell us it's very likely we need to be more aggressive just to lower the LDL more. So
Dr. Raskin?
Yes, Laura. Yes.
I was trying to keep up with all of the different tests that we can take, and also some of the supplements you mentioned.
Yes.
I got Vasipa.
Yeah.
As the omega-3 fish oil. Is that the name of a supplement to take?
Well, it's a drug, and that's a distinction we really want to stress, because for years, you know, I would look at Amazon and buy some omega-3, right? We all probably have heard about, oh, omega-3s may be good.
Right.
And then there was a lot of controversy. Are they really good? The only triglyceride lowering therapy proven to significantly lower risk of fatal and non-fatal heart attack, stroke, cardiovascular death is not any omega-3. It's the Vasipa that was proven in a nearly 5-year, 7,000 people study international trial called the Reduce It trial. So that is the only trial evidence, proof that this particular form of omega-3 works. And for some of the people that are not familiar with it, in the Reduce It trial, each capsule is 1 gram. You took 2 grams twice a day, 4 grams a day, 4 capsules, showed this stunning lowering of risk. Now, triglycerides being, quote, borderline, it's no longer just a borderline. It's a marker of increased risk in people who've had vascular. Their LDL could look great, 50, 60. Your trigs are 150. A few years ago, we would have just passed that off. Your triglycerides are a marker of additional risk. The Vasipa, or omega-3s, it's true. Lovaza is another brand. Yes, it lowers the triglycerides when they're very high. We have a lot of drugs for triglycerides. The only one proven, and it turns out to be more complicated than just triglycerides, in the Reduce It trial, Vasipa, a special omega-3 drug, a purified form of omega-3, 98% pure with EPA, that one type of omega-3, lowers risk. It's not the same as going to Costco or listening to Larry King, and he has a product he hawks on TV, a special omega red, whatever it is. Those are supplements, not intended to treat disease and not proven, because these supplements are likely oxidized omega-3. It has to be processed, et cetera, in a very special way.
Rod, do you have a question?
Yes. Yeah, I have a family history of cardiovascular problems on my father's side. Every one of my father's siblings either died of heart attack or stroke.
Yeah.
But my blood chemistry was no problem up until I had my bypass surgery. Should I, or can I ask for an LPA test from my cardiologist?
I think that, you know, we have this concept of shared decision making, and I encourage my patients to talk to me, you know, and of course you would like to know. I'm sure your bypass, you needed it, you're great, but for the future, and again for your own family, other members, if you had ILP-a, for instance, because it's so common in families where the disease is prevalent, like what you were telling me, could be 1 out of 3 may have LP-a. And if you had it, again, your brothers and sisters and children each have a 50% chance, and it might tell them, stand by, there may be a drug for LP-a, and for you too. But for the people who never had an event, preventive care might need to start. And if you have very high LP-a, you might want to start a statin.
Mm-hmm. Yeah,
I'm sure you're already on a statin.
Yeah.
And if you knew you had high LP-a and had a bypass, and our usual goal is like 70 for your LDL, you might want it lower, okay, because you have high LP-a.
Okay. It's interesting you talked about inflammation, and the very year I had my bypass, just prior, I had 2 major inflammatory events. I had my first broken bone 6 months prior, and then I had a cracked tooth at the root level within 3 months. So both of those are probably contributed to inflammation.
It could, absolutely, yeah.
Okay, I
Glad
have
you're doing well. Yes.
Thank you.
I have, Linda, can you?
Yep, hi. So I just wanted to follow up on this, because you're talking about preventative actions.
Mm-hmm.
And for some of us, because those tests were never done, you know, I suffered a cardiac event, a heart attack that I self-diagnosed at the gym after being told by Kaiser 6 months earlier that I had like a 2% chance of any cardiovascular event. You know, they had not done any of the tests. And so now 5 years later, after hearing a webinar similar to this by the national chapter, I asked for an LP-a test, found out it was 170. So I have a very, very, very high risk. So the question is, they started me on just statins 5 years ago.
Sure.
And then I had a very huge jump unexpectedly in the statins. So they changed the statins, added, what is it called? Zetia. And then just recently, in my request to be tested, found out about the LP-a, got referred to the lipid specialist at Kaiser, and just started Repatha. But what the question then is because I have this long history, and you said this probably started in my 20s, plus I have the genetic history, what are the risk factors going forward for someone who's starting, you know, Repatha and such a bigger treatment this late in life?
Well, you still, I mean, the good news, we get it, additive improvement. And so you start off, okay, you're at higher risk, you have disease. What you want to do is prevent new disease from forming. Any residual disease, we hope, shrinks, and that you have clear sailing forever, right?
Yeah.
So the higher LP-a might tell us you need your LDL lower. Additional things are, don't forget what's right in front of our eyes. Triglycerides are on the standard cholesterol panel.
Right.
And for decades, we didn't get excited, really, with triglycerides even up to 200. We knew that if you had triglycerides over 500, someone comes in with triglycerides of 1,000, the risk is for pancreatitis, an inflammation of the pancreas, by the way. And we weren't really aware of 2 things. The risk could even start with triglycerides over 100, Dr. Krauss did those type of studies, that the pattern of LDL may change. So we know that lowering your triglycerides is likely very important. And in the Reduce It trial with Vazipa, someone who had a triglyceride of 135 to 500, irrespective of a beautiful LDL, in fact, the lower the LDL didn't mean you were out of the woods. The triglycerides of 135 or greater put you at risk. And the Vazipa, and don't get me wrong, lifestyle is part of that. Start cutting out the bread, the white rice, the treats that we like, pastries, etc. So you start modulating your diet. It's not all about lowering saturated fat, lowering eggs, for instance. We've moved away from that focus. So I would just encourage you, for the obvious thing is you want to look at your triglycerides, be sure they're lower. If your LDL is hovering around 70, and it sounds like it probably isn't, if you've been on statins and Repatha, you probably want your LDL in below 55. The Endocrine Society in the US, the European Society of Cardiology, even the American College of Cardiology would say, if you're really at high risk, you had an event early, it's your second event, 70 is probably not where you want to be. You want to be at the more aggressive lowering of risk. So in a roundabout way, just by looking at you, an informed cardiologist, even without the additional lab tests, might say, I just think you should be lower. Because since we don't have the LPA treatment, some docs have just said, I don't even need it. Well, if I knew someone had it, I'm more aggressive. And where it's so important is in your children and sisters and brothers. They're fine. Their doc said everything's fine. Like, this is a recurring theme, isn't it? From other people. I thought everything was great until the event.
Dr. Raskin?
That's where it's so important.
Can I follow up with just one question, Laura? Just one thing at the end. You actually talked about this, Laura, and I'm unclear on it. Is there some, you talk about imaging, is there some sort of a test I can request from my cardiologist that will show how much plaque there is?
Well,
because all they talk to me about is angiograms, and we won't do those.
Well, I take it, you mentioned you had an event, a heart attack. Okay. And you're doing fine. And you've never had an angiogram? When you had the heart attack?
Oh, well, when I had the heart attack, I had 2 stents put in.
Okay. Okay. So we don't have optimal ways to track plaque in someone who already had the disease.
Oh.
Not invasively. Number one, insurance doesn't cover it. Number two, it's in studies now, and it may come to pass that we will have non-invasive, meaning without putting you through the risk of a tube in the heart again. As low as that risk is, we prefer to be non-invasive and not put tubes in you every year or every 2 years. So with non-invasive study, it's called a CT angiogram. In some people who are known to have vascular disease, this kind of imaging can literally look at the plaque, just like that slide I showed you where you saw the yellow plaque, and it's an incredible study, but it's not available for routine checking. What we know from the studies, when you're more aggressive, lower is better. If your LDL is below 55-ish and you've had an event, it's more likely than not, and your triglycerides are low, right? Mm-hmm. That you're going to get regression of plaque and no progression. The imaging, just a word about imaging, it's more for how you were. I've heard 2-3 people already say out of the clear blue, they had an event and things look good. So you want to start with, do I have anything to worry about? Am I cooking something? I know that 30 to 40% of women at age 50 over their lifetime are going to have events. 50 to 60% of men at age 50, you can tell them over the rest of your life, we don't know when you're going to have an event. It's very common. This is well known. If you have one more risk factor like blood pressure and you're 50, your risk is higher. That woman with a 30% risk is almost 1 out of 2. On the other hand, there are plenty of seniors who are now being told, you need a statin. What do you mean, doc? Well, the risk calculator says you're now at a level of risk where I think the benefit outweighs the risk. That's how we do risk factor assessment. Age is the biggest risk factor, age. But biological age isn't being measured when you talk about chronological age, right?
Mhm.
How are those pipes doing? Can you assume, oh yeah, you're older? No, you can't. About half of the women probably don't need statins. Why not? They don't even have a touch of atherosclerosis and they're 70 already, right? On the other hand, a 50-year-old who's asking the same question, I'm not taking any drugs, right? At a 50 with a perfect LDL. If you took a look, just like the mammogram, and did the mammogram of the heart called the coronary calcium test, and it showed, by the way, ma'am, the amount of plaque in your coronary looks more like a 75-year-old woman. Your day's a little different. Doesn't mean you have a blockage, it means you have atherosclerosis, and don't you want to stop it from progressing? Wouldn't you like to get a heads up? Because 30 to 50% of the time, the first warning of having this disease that starts off silent, smoldering, silent for decades. You can see it with a coronary calcium scan because of what I told you at the beginning, hardening the arteries, there's some calcium involved in it. So as a risk marker, that's where the imaging really pays off.
Dr. Raskin,
Yes.
if I could go back to the 3 tests that you've mentioned.
Yeah.
The LPA test,
Yeah.
the LPPLA2 test,
Yeah.
and the CRP and high CRP tests. Are there any others that that you mentioned, or could you remind us what those are helping us find?
Sure. The LPPLA2, or the plaque test, is not widely available, and what most of us are now using is available everywhere. It's high sensitivity CRP. That is a marker of inflammation, and we're learning that persistent inflammation is another marker. And since we don't have, again, a therapy to specifically lower inflammation, it tells us to be more aggressive with what we do know can work. It might mean lowering LDL more. It might mean tightening up on your diet. You know what I mean? So it's a marker, and the CRP, that whole concept, we are eagerly awaiting new drugs. And right now, a common drug that many of you know about, colchicine, used for gout. There have been 2 major trials. Last one reported just recently at the European Society of Cardiology, that showed that a common drug, low-dose colchicine, given to people who've had high-risk events and had a high CRP, had lowered heart attack risk, had lower future events as a result of the anti-inflammatory effect of that old gout drug. It's not indicated yet, but you're going to see this in the next year or 2. A whole new class of anti-inflammatory drugs because of this residual risk. So that's the HS-CRP. The
I think we have time
LPA
for
test is very available. Particles often inform some degree of change in diet, or we have to be more aggressive to lower all the particles more. That's the Quest test that was mentioned. LabCorp, other people look at particle number. Now, simpler than the particle number and probably even less expensive is the ApoB protein test. Remember, ApoB protein is on all the bad guys. Most of it's on the LDL. And I'm not saying that the tradition that we've used for decades is terrible. I'm saying its precision isn't as good as it should be for about half of the people, particularly when you don't know there's any risk. You see what I'm saying? We start with the regular panel. And for many of my patients, I still use the regular panel for follow-up after I've looked at this Lp(a), which really should be looked at once if you want to know about your risk.
Dr.
Right? That's a
Raskin,
genetic test. Yes.
Yeah, I think we have time for maybe one more question. And Dave Schmidt, you had a question, I believe. And have I unmuted you? Yes, I have.
I'm unmuted. Yep, thanks a lot. You had
Sure.
commented about diet and white bread, white rice,
Right.
what to stay away from or what to minimize. That's part A. Part B is what about exercise? What kind of
course.
exercise is good?
Yeah.
Because there are all different kinds of exercises, weightlifting,
Yeah.
running, walking.
Yeah. Let me go. But the diet obviously is important, and it's not percent carbs or percent fat or percent saturated fat like we've been told for years and years. It's a healthy all around, more like a Mediterranean pattern. And what that means, more fruits and veggies, minimal amount of meat, and I'm going to put an asterisk on meat, processed meat, bacon, sausage, that kind of thing is considered by the World Health Organization as a carcinogen. So if we say a little meat's okay, it doesn't mean all your meat should be processed. And do I recommend low carb or low processed carbs for everyone? No. Those people who have, about half of the patients I see, diabetes, pre-diabetes, triglycerides that are elevated, those are the folks that want to reduce simple sugar. And people forget there's the same amount of sugar, about 8 teaspoons of sugar in a standard 8-ounce glass of juice or soda. Big culprit. So you want to reduce that. You want to reduce the simple white flour products and move to whole grain. Exercise, whether it's aerobic or isometric with weights, both have additive benefits. Most of the science would say, even going back to the Surgeon General, Everett Koop, 10,000 steps a day has a health benefit. In Great Britain, the Million Women study looked at those women who were more active versus less active, and they actually tracked from housekeeping, gardening, shopping, versus those people who were sedentary. Dramatic benefits. And of course, that extends to no smoking. Top is good nutrition, which is real food, more fruits and veggies, less processed foods, less hidden sugar, added sugar, and sodium. It's kind of a general, Mediterranean pattern, has most of the science. And then there's nuance to it. If you're a person with triglycerides that are elevated, more inflammation, because inflammation often travels with the triglycerides, cutting down the simple carbs and sugar matters a great deal. And exercise is clearly excellent. Very, very important. That's why we have cardiac rehab, to get people very motivated. And the real problem aren't so often the mended hearts folks know about this. It's the folks who are sitting around not doing anything. That's where the real problem is. It's such a big piece of health to avoid having cardiovascular, moving more is one of the big things, along with diet, not smoking. You're right. But I think I'm talking to the choir here, preaching to the choir.
Okay, Dr. Raskin, thank you very much. Susan, did you have any last comment as president or anything?
I would like to thank Laura for getting Dr. Raskin here, and I'd certainly like to thank Dr. Raskin for an absolutely outstanding presentation.
I totally agree. Okay, thank you, Dr. Raskin. Goodbye, everybody. Have a good day, a week.
All right, everyone stay safe. Thank you for your comments.
Thank you.
Thank you.
All right, bye-bye.
Yeah, they just finished. Or at least I tried to finish.